Welcome everybody. My name is Jean-Paul Moati. I used to be a health economist involved in the field of AIDS, but now I'm the chair of a French Institute for Sustainable Development Research. And I have a pleasure to co-chair this session with my friend Bruce Shackman.
Hi, I'm Bruce Shackman, and I'm a professor at Weill Cornell Medical College in New York City in the Department of Healthcare Policy and Research.
Thanks for being brave enough to be in an economic session in an HIV conference. So the idea is that we will have a 10-12 minutes presentation by each of our colleagues. And then I hope we will have time for questions from the field. We'll take questions after each presentation. And that's my pleasure to, since my institute works a lot in Vietnam, this is a great pleasure to introduce Anh Thuy Duong from Vietnam, that will talk to us about an experience with methadone treatment. Anh, please. And if you don't mind, and I will tell you when you will have only 2 minutes left. Is it okay?
Yeah.
Good.
So, good afternoon, dear Chair, Co-Chair, distinguished guests. It's my pleasure to be here to share with you what Vietnam has done so far to expand our methadone program. So we applied our user-fee policy in 2014. And this study is starting since then because we want to explore if there is any association between user fee and dropout from methadone treatment program. My presentation will cover 4 study background, objective, method, result, and also conclusion. You know that up to now we have been provided treatment for more than 53,000 patients in Vietnam, and the treatment is provided almost at government-owned health facility. And in that health facility, we also apply the user fee for almost the services. In this context in Vietnam, when the donor fund diminishing, so we have to apply the user fee for to sustain use as an alternative funding sources to maintain the program. And for the user fee, normally the government have our user fee from framework apply for 63 province, and in that province, the province can use a framework, and they can fluctuate around 70% to 100% to use that the framework. For the collection, the facilities they can collect by the quarterly or monthly basis, but it depends on the facility they can use as a daily basis if they want. Come back to our methadone program. It's almost subsidized from the international project, and when the government have been notified that it will be diminishing, so we have to decide to apply the user fee for some facility. We start pilot in one province. So some study for the previous time, so that the collection, the user fee collection is possible. And in some provinces, because they don't have funding available, so they can collect user fee for several services like the mineral water cup or some material for the service. So that this study will come to understand whether the user fee is associated with client dropout. The primary objective of this study is to assess the association between the user fee and client retention in methadone. And for the second objective is to assess for the catastrophic payment associated with methadone. This study starts for like a cohort study for 1,021 methadone clients in 7 provinces from May 2015 and to May 2016. We choose the 7 provinces implementing user fee, and we use a COPS model to explore the association between user fee and dropout. So in our treatment guideline, we define that the client has not come to methadone service at least 30 consecutive days and no reason for lack of attendance. And for catastrophic payment, we use WHO definition of catastrophic payment, more than 40% of non-subsistence expenditure devoted to methadone. We have some reason here. For the dropout, at province with user fee policy, we see that 90% of clients has no dropout, comparing with the province with no user fee policy have only 89%. We also have user regression for the three model, and we find that there is no reason of user fee policy reason for the dropout of patient, especially of the province with user fee. We have 80% less of non-dropout there. For the catastrophic payment, we have a different scenario here. For the we have a baseline before when we conduct in that 7 province, and for the end line we conduct 1 year later after we introduce the user fee policy. And here you can see that for the yellow bar line, the end line is higher than baseline, and with province with user fee the catastrophic payment is much higher. Especially at the facility level, it can go up to 70%, 23%, and also 38%. For the dropout, it's very special for Ministry of Health when we conduct this study, because we want to explore any potential reason for the dropout of patient. So in that study, we have a two group. The active clients, that means they still under the treatment. And for that group of patients, there is only 6% of them think that the user fee is one of the reasons for dropout. But for the other, like the traveling, because they have travel every day to drink the drug, and 21% of that feel that the travel is one of the reasons for dropout. 20% of them feel that methadone was not helping them anymore, and 20% of them find that it is difficult to adaptable with the regulation of methadone, like the opening hour, because almost the client go to the morning to drink the drug. And only 11% of patients feel no longer needed methadone. And we have another group of patients when they have lost to follow up. For that patient, we can go into the different channel, like as they contact to them. If we could not contact to them, we can contact to their representative, like father or and their family, and to ask them about the reason why they drop out. So in that study, only 2 out of 19 think that the payment is one of the reasons for dropout. It is not much comparing with the other. And also 20% of them feel that the traveling is a reason for dropout with that patient. And 50% of them feel that they could not adapt with the working of the methadone clinic, like opening hour in the morning. And 10% feel no longer need methadone to stay off of heroin. For the conclusion, we find that there is no association between for the user fee and also the dropout of patient. But because the study have conducted only 1 year after the user fee policy applied in Vietnam, so it can have need some explorer later. And 2 out of 19%, that means around 10% of dropout clients think that the payment is not the reason for, is a primary reason for the dropout. For the recommendation, we have 4 recommendations. First, we have worked with the Ministry of Health to think that we need a longer follow-up to explore if there is an other potential reason for dropout. And also, we work on the policy to work on different group of patients to explore if we have a policy to exempt some people for user fee policy. That is my presentation. Thank you.
You can stay, Anne, because thank you, Anne, because we've been clear and short enough for letting some good time for discussion. So please introduce yourself before asking your question.
Hi, it's Ruben Granch. I'm with IPAC in Washington, D.C. That was a great talk, and I just have a question or something to consider. When you look at the people that have dropped out, have you considered the amount of money that you will actually be able to get through user fees may be smaller than the amount of money that those people, when they drop out and, let's say, transmit HIV or get sick or do these sorts of things? Has that been part of the consideration when considering user fees? I hope that have I been clear?
Can you rephrase it again?
Yes. So the question is that it's a very interesting study, and I see that a small number of people are dropping out.
Okay.
But I was wondering whether when the idea of giving user fees, the idea is to get money in, but maybe the amount of money that's coming in is less than the people that, even the small number of people dropping out, who later may be very expensive.
Yeah, I think it's a really interesting question. And as in my presentation, this study conducted only in 1 year after we apply for the user fee policy. So it can maybe not long enough to collect the all information of patients for dropping out. And here in this study, we have only 2 people dropping out. And you know, in Vietnam, the patient on methadone is almost the ideal patient, and they are very typical group of patients. When we come back and contact to them, it's very difficult. We use different way to contact to them, like through their family, through the clinic, by different way. And you know, they spend around here in Vietnam, when we use the fee, we collect the fee. It's only $5, 5 cents a day for drink methadone. But if you use they use methadone, they can use up to 100 times higher than that. So you know, for the methadone, even from the patient side, from the family side, they think that it's really a very cost-effective program comparing with the patient. But in this study, we don't find the fee as a main reason for dropping out, because the patient think that it's really a cost effective even for them, because they can come back to normal work, they can help to earn the revenue for their family.
Can we have another question? Because we have time for another question. Thank you.
It's just slightly related issues. Have you looked at the cost of administering or monitoring the user fee program? Because say in many countries, when we charge prescription charges, we find that actually you spend more money monitoring and doing the actual user fee program than you get back in return. So it's whether you've costed the actual user fee program at the things and compared that to how much you generate in return. Thanks.
Thank you. And if I may add something else which is related, Anne, is that it is unclear to me what was the main rationale for introduction of user fee. Was it to improve funding of facilities, or other rationale, like, maybe the idea that it could improve the interest of the patients into a program?
Yes. The methadone here is almost subsidized from the international donor. So when we apply the user fee, the first thing we think that it can be used as alternative funding to sustain the service. And from this study, we just cost all the fee relief from the patient side. We haven't cost for the other, like the provider side. But you know, if comparing with other substitution treatment, comparing with other military, it can the government say that it is a very cost-effective program.
Thank you very much, and so we'll thank you. Thank you very much. Bruce?
Excuse me. So I'm now going to introduce Colin Mangina from the Center for Sexual Health, HIV and AIDS Research in Zimbabwe. He's going to talk to us about the economic evaluation of non-financial incentives, nice segue, to increase couples' HIV testing and counseling uptake in Zimbabwe.
Good afternoon, ladies and gentlemen. I'm here to present, on behalf of my colleagues, results of an economic evaluation of non-financial incentives to increase uptake of couples' HIV testing and counseling in Zimbabwe. I have no conflicts of interest to declare. So I'll start by giving a background to the study, talk about the methodology, give you results and the conclusions. By way of background, 2012 WHO guidance recommends HIV testing and counseling services for couples. This is not only because it guarantees joint disclosure of status and support from a trained counselor, but it also ensures higher uptake of prevention, treatment, and support services. Studies have also shown a 2/3 decline in transmission among discordant couples post-test. Despite the aforementioned multiple HIV prevention benefits, uptake of couples' HIV testing and counseling remains suboptimal, with only 30% of people globally who seek HIV testing taking up couples' HIV testing and counseling. Reasons behind this state of affairs is the fears around relationship instability or possible revelation of undisclosed sexual behavior. And from a behavioral economics point of view, clients may discount the longer-term benefits of couples' HIV testing and counseling even when they outweigh testing alone. Along with the rest of countries in Southern Africa, which include South Africa, Mozambique, Swaziland, and Zambia, uptake of couples' HIV testing and counseling remains very low in Zimbabwe. And this is despite the fact that in some instances extensive mobile testing is provided, coupled with community mobilization visits in the rural areas 1 week prior to visits. For Zimbabwe and other low-income settings, which are considering strategies to increase uptake of couples' HIV testing and counseling, it is also important to ensure that such strategies are low cost. Within the context of a cluster randomized controlled trial that measured the impact of incentives on uptake of couples' HIV testing and counseling within 68 rural communities in 4 Zimbabwe districts, we conducted an economic evaluation to assess the cost of non-financial incentives for increased uptake of couples' HIV testing and counseling. Small non-financial incentives were found to be effective at increasing uptake of couples' HIV testing and counseling by counteracting present bias preferences and focusing the minds of clients on the incentives rather than the immediate costs. Clients in the incentive arm, in addition to standard mobilization, were offered the choice of one of 3 grocery items worth $1.50, US $1.50, and the choice was between a bar of laundry soap, a jar of petroleum jelly, and a bottle of cooking oil. The primary outcome of the cluster randomized trial was the proportion of individuals testing with a partner. For our cost analysis, the measure of value was the incremental cost of the incentive arm over the standard mobilization arm. We took a provider perspective Main outcomes of interest were the cost per individual testing with the partner, cost per individual tested, and cost per HIV positive diagnosis. We collected data on actual purchase prices from the provider. We collected data on quantity and cost of incentives, personnel, equipment, HIV test kits, stationery, and other supplies. So on this slide, I'm presenting results of the cluster randomized trial. We spent more outreach team days in the incentive arm compared to the no incentive arm, but it also ensured almost 4,000 more number of clients tested and counseled, a higher number of tests per day, and almost 40 clients were almost 14 times more likely to test as a couple compared to the non-incentive arm. In the incentive arm, we also registered a much higher seropositivity rate. Previously, the challenge has always been getting males to participate in testing programs, in PMTCT programs, but in this incentive intervention, there were a lot more testers in the incentive arm compared to the non-incentive arm. For the incentive arm, the unit cost per client tested was slightly lower than the cost per client tested in the no-incentive arm, despite the fact that a lot more resources were invested in the incentive arm. So the incentive arm compensated for the extra investment by registering a lot more clients testing, as a couple, and also by capturing a lot more HIV positive clients. So if you look at the cost per HIV positive client, it's actually much less than in the no incentive arm. The incremental cost of the incentive arm over the standard mobilization arm was about 26,000. But if you look at the cost per, the incremental cost per client tested as a couple at almost $4, and the incremental cost per HIV positive client at $48, we believe it is value for money if you consider the 6,437 additional clients tested as a couple. In conclusion, simple low-cost interventions are required to scale up public health services and to close the tape on new infections. Provision of non-financial incentives are not only an innovative strategy for increasing uptake of couples HIV testing and counseling, but is also highly affordable. For policymakers and providers who are considering strategies to increase uptake of couples HIV testing and counseling, we highly recommend non-financial incentives. I would like to acknowledge our partners, funders, and regulatory authorities who gave us ethical approval. Thank you.
This paper is now open for questions. I see one coming towards the mic. Oh, go ahead, far mic.
Okay. Thanks, a great presentation. Alexander Constant with the Uplang Institute. I was wondering about the amortization that you mentioned. 3 to 5 years, I think, in the...
Okay, sorry.
3 to 7 years. What did that apply to, and why did you do that?
Sorry?
What did that apply to? It was amortization of which costs, and why did you do that?
Okay.
Thanks.
Okay. All right.
Go ahead.
I'll just answer. Okay. So the 3 to 10 year amortization period was applied on furniture and equipment, and so it depended on whether we're looking at furniture or equipment. So we just varied it between 3 and 10 years.
Thanks, just for the fixed cost.
You're welcome.
Hi, Jennifer Weston from Interhealth International. I'm not an economist, so this isn't going to be an economics question. I'm just wondering, you said that in the non-financial incentive, or before the non-financial incentives, there'd been a lot of sensitization and people weren't coming as couples. So I'm wondering, how did you sensitize communities to get so many couples coming in, so many more men coming in? And was it a different type of sensitization? Could that have accounted for part of the effect?
Standard HIV testing provided through outreach is preceded 1 week prior by a community mobilization visit into the community. So community members are alerted to the fact that an outreach team is coming into the area, and they are alerted to the time and the place where the mobile outreach teams will be based. So in this particular case, the difference was, for both arms, standard community mobilization was provided, but for the intervention arm, community members were alerted to the availability of that incentive if they tested as a couple. I'm not sure if I fully answer that.
Go ahead.
It's kind of a non-health economics question, but mainly about a trial. So you see there was about a 50% increase in the number of people getting tested, but there's a six-fold increase in the number of couples tested. So as we go on towards that first 90 target, and we're scaling up all varieties of testing service, do you think we're actually going to see a decline in couples testing because more people will have access to just a testing service, and so less and less people will, more people would have tested already and wouldn't be waiting for a couples testing? Does that make sense?
Please come again.
No, as we scale up testing services, you're actually going to get people just testing on their own, and we may have a negative impact on couples testing because people would have just tested anyhow because they would have come in contact with self-testing or other forms of testing. Because there was only a 50% increase in the number of tests, but a six-fold increase with this incentives, but not that much increase in the total number of tests. So as we kind of flood the market with more testing modalities, people will just test on their own, and there won't be as many people couple testing anyhow, like a replacement effect. There won't be a replacement effect.
Question
From the trial, do you think that will happen?
Sounds more like a comment than a question.
Well, it was more that, will you see that happening over time in your study that...
Oh, during the study, did you see, I guess you're saying during the study?
Yeah.
Did you see a reduction in the rate of couples coming in, or was it pretty consistent throughout the study?
And based on distribution of testing?
Just what was your observation?
I think it was...
It was pretty consistent throughout the study.
Yeah.
I had a question that was based on the cost numbers. It looked like that your number of tests per day went up significantly, was like 56 per day, and then went up to 70 per day, so that's like about a 25% increase. But your human resources cost didn't go up as fast. So was that because there was some excess capacity in the system to absorb that extra demand, or is it just when couples come in, you can do the tests faster?
I think it's probably also one of the issues. I think I sort of left out the extra capacity. We saw evidence of opportunities for economies of scale, and if community mobilization efforts were intensified, we are likely to see a reduction in the cost of personnel.
So they're just becoming more efficient.
Yeah.
Great. Any other questions? I think then I have one comment for you also, which is I think because you have 34 different sites and a distribution of different of results, you have the opportunity to do some sensitivity analyses looking at the effect at different sites with low volume versus high volume, and I think that would add some further insights that would be of practical use when you go out into the field where you're going to have some variation. So I think that would also be useful. Thank you very much.
Now we turn to rural Tanzania, and it's Caroline Faye from the University of Berkeley in California about the effects of short-term cash and food incentives on food insecurity and labor force participation among HIV-infected adults with antiretroviral therapy.
Good afternoon. On behalf of my co-authors at the University of California, Berkeley, and in Tanzania, I'm pleased to present the latest results from our trial of cash and food transfers in Tanzania. Food security, defined as inadequate access to food of sufficient quantity and quality, or the inability to acquire food in socially acceptable ways, is widely recognized as a barrier to adherence and retention in HIV care. Food insecurity is hypothesized to impede care through multiple mechanisms, a few of which include undernutrition and weakened ability to engage in livelihood-generating activities, such as formal and informal labor force participation. These circumstances force people to make difficult decisions between food and other goods and services, including HIV care. This is a very oversimplified depiction of a complicated relationship between food security and HIV, but focuses on factors that I will discuss today. To address this barrier, we conducted a randomized trial of short-term cash and food incentives for food insecure people initiating ART in Tanzania. Provision incentives were selected as an ideal intervention for vulnerable people just starting ART. Note that other interventions, such as livelihood programs, may be more suitable at other times. In previously presented and published results, we demonstrated that incentives increased ART adherence and retention in HIV services. Participants randomized to receive incentives were significantly more likely to achieve medication possession ratio greater than 95%, an indicator of adherence. These findings add to evidence from other low and middle income country settings. Today's presentation will delve further into our Tanzania data in an effort to understand the pathways that led to our results. Although we know that cash and food assistance can improve adherence, there's limited evidence for whether incentives alleviate the barrier of food insecurity. We hypothesized that cash and food assistance could improve food security and livelihoods, in turn increasing adherence through income effects. An alternative hypothesis is that incentives act through the price incentive, compensating for costs of clinic attendance, including transportation and time, but do not directly improve patient well-being. Previous studies have yielded mixed evidence for the effects of food and cash assistance on food insecurity among people living with HIV. Studies in Zambia, Haiti, and Honduras all reported improved adherence with food assistance, but mixed results on food insecurity and nutritional status. Few studies have examined the effects of cash transfers among HIV patients. One qualitative study in Malawi reported increases in food security, as did a livelihood and finance intervention in Kenya. Conclusions are limited by differences in study design, attrition rates, and the length of time that participants were on ART before receiving assistance. To address this gap and better understand pathways to our previous finding of improved adherence, we examined whether cash and food incentives also improved food security, nutritional status, and participation in livelihood activities. The study was conducted at 3 HIV primary care clinics in Shinyanga, a rural region of Tanzania. HIV-infected patients were eligible for the study if they were at least 18 years old, initiated ART 90 days or less before enrollment, and were food insecure. Patients were excluded if they were severely malnourished due to their need to receive special nutrition and clinical support for recovery. Participants were randomized to one of 3 study arms. The comparison arm received the standard HIV primary care services, including nutrition assessment and counseling, while participants in one of 2 intervention arms also received the standard of care, plus the opportunity to receive either a monthly cash transfer of about $11 or an equivalently valued monthly basket of local foods. Participants were eligible to receive cash or food assistance for up to 6 consecutive months, conditional on attending scheduled visits. And for this analysis, the 2 intervention groups are combined to increase efficiency. As I mentioned, we previously examined adherence in this population, and for this analysis, outcomes include food security, nutritional status, and participation in livelihood activities. Food security was measured with 2 validated scores. The Household Hunger Scale measures the most severe experiences of food insecurity and is a subset of the more comprehensive Household Food Insecurity Access Scale. Nutritional status was evaluated as body mass index and weight gain. And livelihood measures included current work status and functional limitation, defined as the inability to do work or housework due to illness in the past 6 months. And down the hall, we also have our team has some posters on expenditures and effect heterogeneity among this population. Participant characteristics are presented here. At enrollment, the mean age was 37 years, and 64% of participants were female, and the mean CD4 count was 210 cells per microliter. Participant characteristics were balanced at baseline with the exception of age, language, and occupation. At enrollment, 41% of participants were severely food insecure. The mean BMI was 21.5, and 58% were working. Baseline outcome values were balanced except for weight. After 6 months, participant weight was abstracted from clinical records, and a follow-up survey was conducted. 6-month data were not available for participants who transferred, died, dropped out of care, or were missed due to poor clinic attendance. The incentive's effectiveness at increasing retention contributed to greater availability of follow-up data among the intervention group. So to account for potential selection bias, our analyses used inverse probability weighting, or IP weighting, a common method to adjust for missing data. Briefly, weights were generated using logistic regression for the probability of missing assessments. And this method assumes that data are missing at random, conditional on observed characteristics, and that the missingness model is properly specified. 6-month results are presented here. After adjusting for baseline imbalance and IP weighting, we did not observe any significant differences in food security or nutritional status. 13% of the comparison group were severely food insecure, along with 10% of the intervention group. The comparison group gained an average of 2.1 kilograms, similar to 2.4 kilograms gained by the intervention group. There were also no significant differences in current work status. However, participants in the intervention group reported significantly less functional limitation. Again, that's the inability to do work or housework due to illness. And again, I'll remind you that in previous results, we found significant improvements in adherence and retention. Despite the lack of differences between groups, all outcomes substantially improved within groups, comparing baseline to 6-month values. These improvements may be due to the benefits of starting ART. As I'll remind you, our study population are all ART initiates. Several studies have demonstrated that ART has positive effects on food security, nutritional status, physical health status, and labor force participation. These results have several limitations, the most important being attrition. However, we did attempt to mitigate bias from missing data using inverse probability weighting. We plan to conduct sensitivity analyses using other missing data methods. We also had a number of self-reported outcomes, which may be subject to social desirability bias. An additional limitation is that any small effects of cash or food might be obscured by the strong effects of starting ART on individual and household well-being. In conclusion, we previously found that cash and food incentives increased adherence and retention. Food security and nutritional status and engagement in livelihood activities substantially improved within both study groups after 6 months newly on ART. Short-term cash and food incentives did not augment these gains relative to the standard of care, with the exception of significantly less functional limitation. These findings suggest that cash and food acted primarily via the price incentive, increasing ART adherence by mitigating cost barriers, and rather than via income effects, meaning that the incentives did not significantly improve patient welfare above and beyond the effects of starting ART. Future studies are needed to better understand long-term effects, including the mechanisms through which incentives may increase and sustain retention in HIV services. I'd like to acknowledge my collaborators. Thank you very much.
Questions? I'm very much interested in your study because, as you may not know, I'm a member of a panel appointed by the UN Secretary General to evaluate the Sustainable Development Goals, and our main focus is on the interactions between the SDGs and, for example, between health and food security and this one. So what will be the main policy conclusion and recommendation? Basically, you're saying that the main policy recommendation is that the impact on the other SDGs to increase access to essential medicines, right?
Yeah, so the takeaway isn't that the cash and food incentives weren't effective. They did improve our main outcomes that we were looking at in this study, being adherence and retention. And through improving adherence and ART, the patients' food insecurity and livelihoods are expected to improve just by the benefits of becoming healthier and being able to go back to work and so forth.
Thank you. Questions? Other questions?
Yeah, hi, Jeff Gottlieb, University of Washington in Seattle. Two questions. One is, did you look at the subset of severely food insecure individuals, and did they have a different outcome than the combined population? And then number two is, given these were monthly incentives, what percentage of daily food use or cash household income did this cover? And would you expect it to be a significant enough level of food supplementation or cash incentive to affect the family food use or income during that month?
Yeah, so that would obviously vary by the household size, and the incentives were not targeted by household size, but we did intend the incentives to supplement but not replace the household food supply. And can you remind me what your first question was?
The severely food insecure folks, did they have a different outcome than the population as a whole? Did you look at that subset?
We haven't looked at that, but that's a great idea. Thank you.
Thank you. A last question? Okay. Thank you very much, Connie.
Thank you.
Okay, I'm going to introduce Chun-Quinn Lin from the University of California, who's going to speak to us about using conjoint analysis to model hospital directors' decision-making in adoption of an evidence-based stigma reduction intervention in China.
Okay, thank you for the introduction, and I'm very gratitude to have the opportunity here to present my work. And I have no conflict of interest to declare. And just a little background of my research. As you know that there are numerous evidence-based interventions have been developed every year to tackle a variety of health issues. There are 4 presented here, randomized control trials, all demonstrate efficacy in randomized trial conditions. However, my question is, when the research money take away without some outside supporters, how do hospital stakeholders would like to adopt this evidence-based intervention models? So I use a randomized control trial named White Coat Warm Heart, which is implemented by our research team as an example to study the issue. The White Coat Warm Heart, shortened as WW intervention, was conducted by 40 county level hospitals in 2 provinces of China, and using a combination of popular opinion leader and dissemination of universal precaution supplies, the intervention showed reduced prejudicial attitude and avoidance towards people living with HIV. So this randomized control trial has been published in American Journal of Public Health. So So I use conjoint analysis to study whether hospital director would like to adopt this intervention model. So what's conjoint analysis? It's a technique that's often being used by market research to determine how consumers would value different features of a product when making purchase. So say, for example, when you are buying a house, the price is important, the location is important, the size is important, the school district is important, but which one of those features are more important than others? So instead of presenting a series of single features, one at a time, market researcher will present a few houses with different combination of these features to force consumer to make trade-off decisions. And how you make the decision will reflect how you value these different features. So when apply this conjoint analysis to study intervention adoption, we first have to decide the features of the intervention. So intervention now act as a product, and then hospital directors will be our consumers. So we conduct literature review and in-depth interview with hospital directors and determine there are 7 most important features that will impact their decision-making in adoption of evidence-based intervention models. They are whether administrative support is available, and second, the cost, and the personnel involvement, and if the format is flexible, and the duration of training, and availability of technical support, and if stigma reduction is a priority in their hospitals. So to avoid complexity, we assign 2 levels to each of these attributes, a preferred level and a non-preferred level. So because 7 parts 2 equals 128, so there are a total of 128 possible combinations. It's definitely too many to administer, so I use a fractional factorial orthogonal design to reduce the combination number of scenarios to 8. So this step can be realized through a SAS macro. So the 8 scenarios is presented here. Say, for example, for the first scenario represents the intervention with minimum and administrative support. The cost is relatively cheap, but it involves 50% of the personnel in the hospital. It requires short-term training, like 1 month, and the format being flexible, and the technical support is maximum, and the priority of reducing stigma is not the hospital's a priority. So the participants are hospital directors, 60 hospital directors recruited from 30 different levels and types of hospitals. They're 1/3 from provincial level, 1/3 from city level, 1/3 from county level, and there are 2/3 from general hospital, 1/3 from specialized hospital, and about 10 hospitals were the original or participate in the original WW intervention. So in order to participate, they have to be a director or deputy director in a hospital. So they have to have some decision-making power in the hospital to participate. And we have explained that it's a research, what they answer is not part of their job. And then, so the conjoint analysis is administered on a 101 phase, 2-phase base. So our interviewer first introduced the purpose, design, and outcome of the intervention, the WW intervention, and demonstrate that it has shown effect on stigma reduction in their hospitals. And then the interviewer presented the 8 intervention scenarios using a set of answer cards as shown in here. And the hospital directors were asked to rate the possibility of adopting the intervention for each of the scenarios. And there are 5 categories acceptability rating, from 0 equals to highly unlikely to 5 equals to highly likely. So then mixed effect model was fit to the acceptability rating as an outcome, and the 7 attributes are served as independent variables in the model. Because there are 8 scenarios nested within each respondent, so this model includes a respondent level random effect. And the regression coefficient of each attribute is the impact score of the acceptability. So the outcome looked like this. So the cost of the intervention had the greatest impact score, followed by the duration of training. And also the format and availability of technical support also had an impact on hospital directors' decision-making. And other 3 factors, including administrative support, personnel involvement, and priority alignment, did not reach statistical significance. So compared to conventional prioritization method, this conjoint analysis provide more scientific rigor by quantifying the relative importance of each feature of intervention. And then the model we build here has the potential for stimulation to predict in the future how hospital directors would like to adopt certain evidence-based model. Also, this we use the real-life evidence-based model as an example, and some of the hospital directors actually participate in the original intervention. So this method provides more realism in prediction, and the 8 scenarios allow side-by-side comparisons. And I have to point out the feasibility of this method. So the majority, like 88% of the hospital director reported the administrator of conjoint analysis was clear and easy to understand, and it takes them about 10 minutes to complete the conjoint administration part. And but some of the respondents did point out that the scenarios generated by the mathematical model may be unrealistic to them and lack of practical meanings. So in the future application of this method, we had to consider the actual meaning of those scenarios generated by SAS. So the findings has implication for intervention development and then delivery, because the intervention has to be simple and cost-effective, especially in the resource-limited settings. And also you have to consider the service provider's busy working schedule, and the training with greater flexibility and control of time will achieve more buy-in from the hospitals. And you have to provide continuing technical support to facilitate the adoption of the intervention models. So I have to acknowledge the funding agency, the local collaborators, and my team members and mentors. So, thank you.
Congratulations on using conjoint analysis in a very creative way with hospital administrators. We often don't think about the healthcare system. We think of it as a barrier, but we don't think about collecting their preferences and designing to address those preferences. This paper's open for questions, if there are people who have questions. Go ahead.
Thank you for the presentation. My name is Stephen Pan from the University of North Carolina at Chapel Hill, but I'm based out of Guangzhou. I found it. Thought it was kind of interesting that in the list of attributes there, I think stigma priority of addressing stigma in the hospital would be included as an attribute, because I guess that would seem to be like a characteristic of the director and the institution that he or she would represent, rather than a characteristic of the service that they would be thinking of adopting. So I guess my question is, if did you have a chance to look at any sub-analyses of perhaps directors who did feel like their institution was prioritizing addressing stigma or other kind of subgroup analyses?
Yeah, I did look at, I originally intend to look at different factors of hospital, may have some association with their decision making, but due to the limited sample size, because we only have 60 hospital directors, so we didn't find any significant association between any of their individual characters, hospital characters, and their decision making. It's a limitation of the study.
We have another question over here.
You from China CDC. My question very simple. What's your recommendation to government based on your study result?
I would say the first recommendation is that the WW intervention is very effective in stigma reduction, and it has great potential to be adopted in healthcare settings to combat HIV-related stigma. And the second is that the intervention package can be adapted in terms to, say, for example, to provide more flexibility. For example, the original intervention is group-based, and if we can adapt it to like internet-based to reduce the costs and the personnel involvement, it has a greater potential to be used in hospitals.
Thank you.
Thank you very much. Thank you. Now we turn to Ukraine with Ludmila Komish from Deloitte Consulting Overseas Project, who are going to talk about willingness and ability to pay for drug substitution treatment in services in Odessa.
Thank you very much for introduction. It's so pleasant to be here and to present for you some funding from Ukraine. So I would to mention that this study is supported by and supported within project HIV Reform in Action, which is supported by PEPFAR and USAID. Here is a short outline of my presentation. But let's talk about Ukraine. What it is important for us to know what is the willingness to pay for ST clients. Ukraine is the second highest HIV prevalence rate in Eastern Europe country. It is accounted for more than 238,000 of people living with WHO. And it is also concentrated epidemics with people, PWID, female sex workers, and MSM. Here, as you can found the numbers of this key population size estimation, and you see that the population of PWIDs is quite big in our country. What about OST programs? It is available for our clients since 2005, And as of June 1st this year, more than 9.6 thousand OST clients receiving these services in 177 sites over Ukraine. But if we're talking about coverage by OST programs, it's quite low because it's only 2.8% out of all estimated number of people, injection drug users. So when we're analyzing the showing analysis of funding sources for OST programs in last years, we can show that the most important funding sources is international. And we have increased in absolute numbers of fundings for OST programs. The role of international donors is quite big. But taking into account potential financial reduction of the international support of OST programs, and on one hand, and on the other hand, we have Ukraine economic crisis, because you know, annexation of Crimea, crisis in the eastern Ukraine, and what's more, it's Ukrainian hryvnia's devaluation. It's more than 3 times over the last 3 years. So it's quite burden for our country and for our people. So our project started to thinking about building and piloting a sustainable model for provision of the critical services for key population and people living with HIV at the rural and city level, because it's quite important when there are no funding, international funding in these settings, to secure this acceptability to these key services. And the implementation of the alternative financing model, such as co-payment, is optimal way to secure critical for PWD services. But we don't know are there a willingness and ability of our current OST clients to pay for some OST services or no. And this is like the main research question in our study before we implement thinking about implementation some alternative models. So again, I want to announce that the financial devaluation of hryvnia is more than 3 times over the last 3 years. So there originally were 7 studies in our 7 pilot regions, but today I will present only one results from Odessa region, which is more important and more interesting for us. Odessa is also very interesting region for Ukraine because it's southern region near Black Sea. It's quite interesting shape of the territory. We call this like a butterfly. And it's one of the highest HIV burden in Ukraine region. There are also concentrated HIV epidemic and HIV prevalence each more than the all Ukrainian rates. The population of people who injection drugs is also quite bigger and bigger than other groups. So, as of today, there are 2 OST sites in Odessa city and 1 more sites in Odessa region, in the southern part of region, and only 1.1% of estimated number of PWADs currently receiving OST services. So, if we are talking about recommended WHO coverage by OST program, it's not enough and very low coverage. But on the other hand, we know there are no additional sources to scale up this coverage and to increase this coverage. So for us, it's important to understand if there are possibility to co-pay by OST clients themselves. So we conduct simple cross-sectional study in summer 2016 among current OST clients in Odessa city. A random sampling strategy was applied, and a simple structured questionnaire we used to interview with our current OST clients. As there was a descriptive study, we use only univariate and bivariate analysis to estimate correlates of clients' willingness to pay for some OST services. There are some basic characteristics of our study respondents. There are in total 161 respondents. Mostly there were males with average age around 42 years. The part of young participants is quite small, it's less than 1%. More than half of our respondents were with secondary education, but the half of the respondents were with single marital status. It is more important that only 1/3 of our respondents have a regular work or job, and they self-report their income like median or lower. And for 47% of our respondents, salary was the main source of income. And want to mention that the average OST duration more than 20 months. It's for 74% of our sample. So we could declare that our sample was with quite OST clients with good retention. Here is the key study results. 89% of our interviewed OST clients declare their willingness to co-pay for some OST services. It's 56 OST clients declare that their absolute willingness to pay, and 87 respondents said that they conditional yes, so it depends on the price of the services. And only 18 respondents say absolutely no. We are asking a lot about perceived benefits or to be an OST client, and we find that possibility to obtain additional medical care on OST site was the most important reason why to continue to stay in the program, even if it will be payable for them. Health improvement and reducing financial burden is also very important self-perceived benefits to be OST clients. We also assessed a lot of correlates with willingness to pay, and 3 not very surprising costs were significant correlated with willingness to pay. It's income per family member, it's self-assessment of financial well-being, and perceived social support. What's more, quite a good percentage of respondents which declare their willingness to pay. But when we are talking about amount of hryvnias, or its Ukrainian local currency, which they could to pay, it's not so big, because most of our respondents pay less than 200 of hryvnias. As of today, it's less than $10. Could you imagine this? So only 10% of our clients, they say that they could pay only between 250 and 500 hryvnias, and only one respondent declared that he has a possibility to pay over 2,000 of Ukrainian hryvnias, but in dollars it's not so much, it's around $77. So we're also asking for what our OST clients are ready to pay. And most of them said that for them it's important to receive therapy for a few days for the future, not to visit OST sites every day, but have the opportunity to come once a few days, once a week, and receive this treatment out of the site. 41% declared that anonymous is also very important for them. 35% say that they are important to buy drugs in the pharmacy and they able and will to pay for that. And last but not at least, very important to increase daily dose and to replace methadone. It was only 24 and 18%. Accordingly, but what is important that these respondents show availability to pay more than 200 hryvnias. So it's like they want to pay for some additional services. To conclude, clients of OST programs in Odessa region demonstrated willingness and ability to pay for some OST service despite of economic crisis in the country. But model amount per month is not so high, it's only 200 hryvnias or around less than $10 as of today. Their willingness depends on socio-economic status of PWAD or his or her family, what is not new for us. But what is important that the correlates of willingness and ability to pay should be considered due for designed and implemented OST co-payment service delivery modeling in Odessa region. And we found during this study that there are a lot of correlates to which we can use for promoting for advocacy campaign among our OST, non-OST potential clients. So what is the next steps? Because the study was conducted in 2016, in summer 2016, and today is the summer 2017, and we taken this into account. From this time, OST costing per patient per month with regional sensitive methodology was conducted, and for Odessa city it was around 915 hryvnias per clients per month. You can see that...
You have to conclude, Elena.
Yeah. You can see that more than half of this amount is for methadone, direct cost of methadone, and less half is for services. We are working now on developing alternative OST co-payment models to choose one or a few of them, to develop policy on OST co-payment model and introduce an alternative models in this region and other our pilot region as well. So I hope that we will have an opportunity next year to present our result of this piloting on the next conference in Amsterdam. And I would also to say a lot of thanks for all my co-authors, fundings, donors, ethical approval, consideration at IRB, at Ukrainian Institute of Public Health Policy, other Ukrainian partners like Alliance for Public Health, National Public Health Center under Ministry of Health of Ukraine. And what is more, it's our implementing partners in Odessa region like Natalia Davidenko, Natalia Kitsenko, and many thanks for Alexander Postnov, which was principal investigator in this study. So thank you for all of you as well as International AIDS Society community and for all contribution to HIV response, not only in Ukraine but in the world as well.
Thank you.
Thanks.
We have time for one or two questions.
Nancy Payton from Berkeley. Thanks for a really insightful presentation. I thought that was great. We rarely get data from those areas. My question to you is, do you, insofar as only 1% of eligibles, or about that, are actually on OST, have you learned something from this, do you think, that might entice other people to join, to avail themselves of this treatment? Like, for example, maybe selling it at pharmacy. That was one of the things that came up.
Not yet, but it is quite in the process. So we are it's like a piloting our project. We are all time on the road. We are working together with our partners in the region and improving in our planning and designing our project.
Demand generation, I don't know.
Thank you. Well, if I may make a provocative comment, sorry, Ludmila, but it's not for you, it's more general, because frankly, health economics has really demonstrated at international level that cost recovery at the point of consumption, which means by user fee, is the most regressive and unequal and efficient way of funding a system. So I understand that the USID is still asking these kind of questions, but my question would be, is there a chance that in Ukraine, and I know that an alternative question should be raised, like how could we build an insurance scheme that would guarantee access to OST services for the people? So it's not a criticism of your study. I'm very sympathetic with willingness to pay surveys. I did the first one in France and get ostracized for 10 years among health economists because I did a willingness to pay study. So I'm fully sympathetic of that, but that's a question that was asked to you, I'm questioning. So is there some debate in Ukraine about an alternative way of financing, which is basically universal health access through Obamacare type?
Yeah. Thanks a lot for a provocative question or remark. It's really hard for our country because, as you know, we are now under health system reform. We are still in the Mashko model health system function, and it is a lot of hard. OST not a priority for health system, and it's really hard to ask for your question, to reply to your question, and really it's wide demand to improve health system in Ukraine as well as priority as for all people, not only for OST clients.
I understand. It was more a question for USID and the Ukraine government than for you. Okay, thanks very much. It was thanks for having shown us that health economics can be, even in this behavioral economics thing, can be useful for HIV. So you've been very brave. I'm sure that 10 years ago we won't have been able to have such a session, and I hope we'll be more in forthcoming conferences. So really, thank you very much.